All right, guys, let's get busy talking about molar pregnancies. We're going to talk about why molar pregnancies happen, how they present, and then a little bit about the management and the differential diagnosis of a molar pregnancy. So you may be asking, like, what exactly is a molar pregnancy? And the way I like to think of molar pregnancies is when placental tissue essentially goes rogue. It's all about the placenta in molar pregnancies. So we have trophoblastic tissue that is made up of the syncytiotrophoblasts and the cytotrophoblasts. And I like to think of the syncytiotrophoblasts as being responsible for making beta HCG, and then the cytotrophoblasts for making the villi that are going to insert into the uterine wall and make that connection with the placenta. And this is what we have in the case of molar pregnancies. We basically have this tissue going rogue. So we have trophoblastic tissue, and this leads to disease of pregnancy because this trophoblastic tissue is essentially dominating the show here. We're going to be talking about two different types of molar pregnancies. Complete moles I will highlight in this red color, and then partial moles I will highlight in this like wine or purpley color. And we're going to talk about the differences between these two types of moles, why they happen, and how they look different on presentation. So let's go ahead and get started talking about our complete mole, which is going to be usually 46XX or 46XY in terms of genotype. We're going to talk about this a little bit more, but let's direct our attention over here to our side-by-side comparison. I want you guys to note that over here, we're going to be talking about our complete moles, whereas our partial moles are going to be in this column over to the right. And when it comes to our complete moles, what is going to happen is we're going to have fertilization of an empty egg or an enucleated egg. So essentially a sperm is going to enter an enucleated egg, and it's not going to meet any genetic material there from the maternal side. And so it's going to go ahead and just duplicate its own DNA. And in the case of complete moles, we can either have XX, which is going to be a sperm carrying an X chromosome that replicates its own X chromosome, or we can have XY. But XY is exceedingly rare in complete moles, and really the only time this happens is when we get fertilization of an enucleated egg by two sperm. But this is very, very rare. In most cases of complete mole, it's going to almost always be XX. We're never going to see a YY. That's just incompatible with molar pregnancy. We won't see it. So let's talk about what happens after we get this duplication of the same genetic material. Essentially, we're going to get domination of the pregnancy by syncytiotrophoblastic and cytotrophoblastic tissue. So we're going to see this as an increase in beta HCG. And this is going to be a massive increase. All these blue dots that I have here are showing the beta HCG, and we're going to get massive amounts of this beta HCG. That's going to be super important. And then additionally, in complete mole, we're going to have massive incorporation of chorionic villi into the uterine wall and massive growth of these hydropic villi all around the uterine cavity. So eventually we're going to get something that looks like this, and you'll be able to see that we have all of this placental tissue taking up the entire uterine cavity, and this actually makes the uterus grow really, really big. So we can expect an overly large uterus in patients who have a complete mole. So let's go ahead and review some of our bullet points related to complete mole. We talked about the fact that it's fertilization of an enucleated ovum, and these are P57 negative. They sometimes like to ask this low yield fact about the fact that complete moles are P57 negative, whereas partial moles are going to be P57 positive because they had the nucleus of an egg, but it's pretty low yield. I just wanted to mention it. And then this one sperm that is going to enter that enucleated egg is going to go ahead and duplicate its paternal DNA, and that is going to make our classic 46XX genotype. That's going to be the most common type in complete molar pregnancy. We're going to get big increases in beta HCG, leading to big increases in hydropic villi. This is going to lead to circumferential proliferation all around the uterus, and this is also going to be associated with a big increased risk of choriocarcinoma. I want you guys to hold on to that fact. We're going to discuss it a little bit later. Now let's compare this to our partial moles, which is going to be a different scenario that is a little bit similar, but also a little bit different. So let's go over it in our diagram. So in our partial mole, we have fertilization of a nucleated egg, or a egg that's carrying genetic material, by two sperm. So two sperm are going to go in there and they're going to meet up with that genetic material. So there's no duplication of genetic material by the sperm here. It's just that we have 3 copies of DNA instead of 2. And so our potential genotypes here are going to be 69XXX, 69XXY, or 69XYY. And those are the 3 possibilities. They're all going to happen with relatively equal probability. It's just going to depend on like whether the sperms were X or Y when they entered that nucleated egg. And essentially what's going to happen here is we are going to still produce increased amounts of beta HCG compared to normal. However, I'm only going to put one arrow here because this is an increase that is not as intense as when we had the complete mole. So you'll see that our little pile of HCG is a little bit smaller here, but it's still going to be larger than usual. And then we're still going to have growth of our hydropic villi here, but it's not going to be as intense as it was here in the complete mole. Additionally, we're still going to have this rogue placental tissue. However, it's not going to be so much so that it increases the size of the uterus. So you'll see that our uterus is still like somewhat of a normal size. And we can appreciate the rogue placental tissue that's kind of growing out all over the entire fetus here. However, it's not going to take up the entirety of the uterus. And additionally, we're going to see fetal parts here in the uterus of a partial mole, whereas we do not expect to see fetal parts in a complete mole. So let's go ahead and go over some of our details. In our partial mole, we're going to have a normal nucleated ovum, which is going to be P57 positive, fertilized by 2 sperm, leading to our 3 different genotypes. We're going to have increased levels of beta HCG, but they're not going to be as increased as complete mole. And then we're going to have minimal hydropic villi and proliferation, and we're going to have a minimal risk of choriocarcinoma. I want you guys to hold on to that fact. We're going to talk about choriocarcinoma a little bit more towards the end. So we've talked a lot about the etiology of our molar pregnancies and how they're dominated by this rogue placental tissue. Now I want to get into how our patients are going to present. So important is going to be our high levels of beta HCG. We expect levels over 100,000 in our patients with molar pregnancies, and this is going to lead to their presentation of increased symptoms of pregnancy. So we normally expect things like morning sickness and pelvic discomfort in our patients who may be carrying a pregnancy. However, these are going to be extremely high in patients with molar pregnancy because we know all of these symptoms are due to increasing levels of beta HCG. Additionally, we can see first trimester vaginal bleeding, which is not unusual in pregnancy. That can be a normal finding in pregnancy. However, in the molar pregnancies, they like to describe this as a prune juice-like vaginal bleeding, and that's going to be a high yield buzzword that is saved for our molar pregnancy presentations. Now, like I said, we also are going to have increased uterine fundus size for gestational age. This is going to be more common in our complete moles because these are going to be really dominated by lots and lots of placental tissue. And then we can also see a grape-like mass in the vagina or the adnexa. They like to use that phrase, grape-like, when discussing our molar pregnancies. Now, if we were to pull out an ultrasound and take a look at these pregnancies, we would see some interesting stuff. And the important language in describing the ultrasound is going to be multiple discrete anechoic spaces along a heterogeneous mass. And we're going to take a look at that in our ultrasound here. And if you look at our ultrasound of our complete mole, you'll see that we have these like anechoic black spaces, right? And it's kind of like this heterogeneous appearance. It's not really the same in any one place. And in our complete mole, it is throughout the entire uterus. Whereas in our partial mole, you can appreciate that anechoic appearance over on this side. And you can also appreciate some fetal parts right here. So we have fetal parts like the head and the what would be the fetus lying right here, and that's going to help you differentiate a partial mole, which has fetal parts. I think of like partial as parts, like they both have P-A-R-T in them, so that helps me remember. And then the language that they're going to use to describe this ultrasound of the heterogeneous mass with anechoic spaces, they like to describe this as a snowstorm or a grape cluster or a honeycomb appearance. Those are all examples of phrasing I have heard used on the exam, and I would say that is really high yield phrasing because they are really wanting you to point out this rogue placental tissue that is the whole root of the cause of our molar pregnancies. I also wanted to just highlight that our partial moles are going to have fetal parts because we have that P-A-R-T, and you're also going to be able to see amniotic fluid in these pregnancies. Now, the moment you've been waiting for, I've been asking you to hold on to knowledge about our choriocarcinoma, right? Because I talked about relative risk, our risk being greater in our complete moles and a little bit less in our partial moles. So let's talk about what choriocarcinoma is. So choriocarcinoma is going to be a complication of of molar pregnancies. And this can occur in either the mother or the fetus during or after pregnancy. And this is going to present with increased beta HCG, but an absence of chorionic villi. And we can also see plus or minus bilateral theca lutein cysts. And so if you have this constellation of symptoms, you may be thinking that this patient has developed choriocarcinoma. And a complication from this that they absolutely love to ask about on exam day is going to be the hematogenous spread to the lungs. And this is going to present with cannonball metastases. And that language is very high yield for describing choriocarcinoma. And a patient with these cannonball mets would present with things like shortness of breath and hemoptysis. We can go ahead and treat these malignancies. They respond really well to methotrexate, and this is because they're going to mimic fetal tissue, and we know that fetal tissue is going to be really sensitive to dips in folate. So if we use a folate antagonist like methotrexate, it's going to be really effective for treating this malignancy. Now, I want to also talk about the management in general of everything related to this rogue placental tissue. So this includes partial mole, complete mole, choriocarcinoma. All that rogue tissue has to be removed. So these patients have to undergo dilation and cutterage. And whenever we do that, we need to also give RhoGAM to prophylax against RH incompatibility. So that's just a note on management. Really, when it comes to getting questions right about molar pregnancies, management is going to be really low yield. It's going to be all about this stuff I talked about up in this section, and a little bit here in the imaging is going to be really important as well. Those are going to be where all the money points are on exam. But before we get to our high yield review, I want to talk a little bit about a differential here. So in terms of our differential for our molar pregnancies, this could be a normal or a twin pregnancy as well, right? We know that twin pregnancies are going to present with increased levels of beta HCG because we have two syncytiotrophoblasts producing that beta HCG, and then it could also be a miscarriage because those can present with vaginal bleeding. However, the normal miscarriage would not be described as prune juice. That is a phrase that we like to reserve for our molar pregnancies. And then also we could have an ectopic pregnancy, right? Ectopic pregnancies can cause pelvic discomfort. And so in an ectopic pregnancy, we would expect to have an ultrasound that does not show evidence of intrauterine gestation. Here in our ultrasounds, we were looking within the uterus. Ectopic pregnancies will be outside of the uterus. And additionally, our ectopic pregnancies, we would expect to have lower than expected levels of beta HCG because that is what characterizes them, because they are struggling pregnancies. They are struggling to form a placenta, and so they have low levels of beta HCG. But in terms of our high yield review, I think it's really important that you know the difference between a complete and a partial mole. So knowing that a complete mole is due to one sperm that duplicates its DNA, whereas partial mole is due to two sperms that are then going to not undergo any replication. They're just meeting up with a nucleated egg. Additionally, I think it's important to know that the beta HCG is significantly higher in the complete mole, and this is what explains the increased pregnancy symptoms that we can see on presentation. And then uber high yield is going to be our ultrasound findings. We talked about things like snowstorm appearance or cluster of grapes, and we saw that down here in our ultrasound. And then the addition of fetal parts, which helps us note a partial mole versus a complete mole. So I would say those are the highest yield details to know about our molar pregnancies. This should set you up to do really well on exam day. I hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye!